A very good morning to all of you. And this is the first lecture and the guest lecture in the Respire 2025 session. And it is on a very interesting topic on advanced management strategies in COPD. And I would like to cordially invite Dr. Jaymin Morjaria, Consultant Respiratory Physician, Royal Brompton and Harefield Hospitals, Guy's and St. Thomas's NHS Trust, United Kingdom. Over to you, sir.
Good morning, everyone. Can you all hear me? Right. It's a bit daunting starting the first session. Thank you very much for inviting me, and thank you for chairing the session. So I hope you can all hear me okay. Thank you. I'm just going to try. So my remit today, if I can go back, is talking about advanced strategies in the management of COPD. And before I start, I'll just go through some of my conflicts of interest, which is very important. And what do I plan to cover today? Well, I'm going to talk to you a bit about COPD, which you all know, and so it's going to be a bit boring to start off with, but some new pharmacological therapies that are sort of in the horizon, just a couple. But my emphasis is going to be on the non-pharmacological management of COPD. This would include the rationale behind it, what diagnostics we do, the MDT that we run, and how it actually works, and then a few tips on or showing you what we actually do, and bronchoscopic lung volume reduction as well as surgical. And remember, I'm not a surgeon, so I've borrowed some slides from my surgical colleague, and I'll acknowledge that at the end. Okay, so COPD. COPD, we very well know, is a progressive lung disease that is characterized by persistent airflow limitation and covers a wide range of respiratory symptoms such as wheezing, cough, sputum production, etc. Quite a lot of the management is quite simplistically managed in our daily clinics with inhaled therapies that we're used to in terms of pharmacological therapies, but non-pharmacological interventions, some of which are on this pyramid, which is vaccinations, smoking cessation, pulmonary rehabilitation, which are very cost-effective and useful techniques. However, as the disease progresses, as things get worse, the patients have more significant symptoms and their quality of life is affected. The lung function is reduced, and they get more exacerbations. And all of these things have a huge impact. And the aim of managing these patients with advanced COPD would be to try and improve on these. So again, repeating on them is the reduction in symptoms, trying to prevent exacerbations and improve their lung function to try and improve their physical activity. We do manage quite a lot of this with what we have, but as things get much worse, we need to try and tackle this in a better way. So what I'm going to cover mainly today, a bit of repetition, is two drugs. One is ensifentrine, which is a phosphodiesterase inhibitor delivered via a nebulized fashion, dupilumab, which you might be aware of, which is a drug that has been used and licensed in asthma as well as atopic dermatitis. Before we go into the non-pharmacological therapies, which is what I've said in terms of volume reduction, bronchoscopic as well as surgical. In terms of pharmacological therapies, the main aim would be to look at chronic inflammation chronic bronchitis and anti-inflammatory strategies. The first drug that I'm going to talk to you about is ensifentrine. This is as I've said before, a dual phosphodiesterase inhibitor, PDE3, PDE4 inhibitor, which promotes bronchodilation as well as reduced inflammation. It is delivered by, as I said, nebulized fashion, and it works on these two pathways to try, and the initial studies have shown improvement in lung function as well as health-related quality of life. When they were further studying this, so this is the phase 3 studies published in the Blue Journal, in the Enhance 1 and Enhance 2 studies, they managed to show improvements in lung function, which we've seen here. And you can see that it's borderline minimal clinical important difference. But more importantly, there was a reduction in exacerbations, as you can see here in the Enhance 1 and Enhance 2, besides the health-related quality of life assessments. This drug works within 5 minutes. It's to be used in addition to what is our current inhaled armamentarium. So therefore, it's sort of an add-on therapy rather than a substitute. The side effect profile is much better than what we know in terms of our oral agents that are available, such as roflumilast. So there's less GI side effects, etc. In fact, there's hardly any, and the most reported are upper airway symptoms like nasopharyngitis. The second drug I'd like to talk to you about is dupilumab. So we know in COPD, most of the inflammation is neutrophilic. However, in a certain small group of patients, there might be a heterogeneous inflammatory profile, which involves neutrophilic as well as eosinophilic inflammation. And it is these patients that this drug would probably be best targeted. We know that it works on the Th2 pathway from the asthma and atopic dermatitis spectrum of studies, and it works on the IL-4 and IL-13 pathways. In the first study that I'm going to talk to you about is a New England Journal paper published in 2023 by a group of well-known COPD experts, which is a global study involving just under 1,000 patients who had eosinophil count of greater than or equal to 300 microliters per mil. And was in a patient group who are on maximum inhaled therapy, which could include bronchodilator or a triple therapy. And these patients were given in a 1-to-1 ratio dupilumab or placebo. And what they managed to show was there was a remarkable improvements or significant improvements in exacerbations as well as lung function. Same group of authors, or a very similar group of authors, published again a year later in a similar cohort of just under 1,000 patients, showing using the same 1-to-1 strategy of dupilumab versus placebo, and managed to show a pretty much replication of the findings, so improvement in exacerbations, which is a primary endpoint, as well as lung function. However, we're not able to show improvement in health-related quality of life. So what does this all tell us? So it tells us that there is an inflammatory pathway, and we can try and target this in patients with COPD. And what they managed to show in these patients, or in this particular two groups, especially in subgroup analysis, was that patients who actually derive benefit. Now, I know that you would say that we already chose them or sub-selected them, but the higher the eosinophil count, the better the response. The more exacerbations that they were getting, the more better response they got. So it helps, dupilumab would help in patients in terms of exacerbation reduction in a patient with a Th2 profiling, in addition to the baseline inflammation. And most of these changes or improvements are noted within the first 3 months of administration of the drug. One would also say, why would it work better than what is already available, the IL-5 agents? Well, the possibility is that because you're addressing two inflammatory pathways, the IL-4 and IL-13, you would probably derive a better benefit in terms of the anti-inflammation from the Th2 side. I will now turn over to non-pharmacological strategies, which is the bulk of what I'm going to be talking to you about. And this is emphysema management. So a bit about emphysema and COPD. It's quite an expensive condition to manage over the globe, costing more than $49 billion in the US some years ago. But we also know it's a leading cause of mortality, the third commonest cause of mortality globally. Emphysema involves the destruction of lung tissue and results in things that we already know in terms of hyperinflation as well as air trapping. And it is the hyperinflation which is the bulk of what I'm going to be talking about for the rest of my talk. We know that as the disease progresses or as the hyperinflation worsens, that the patient's symptoms may get so significant that it may be as bad or even worse than having lung cancer. The effects of hyperinflation would involve dyspnea, a reduction in exercise tolerance, a reduced oxygen uptake, impaired cardiorespiratory function, as well as a reduction in BMI or an increase in BMI, but more importantly, a reduction in muscle strength, which overall has an impact potentially on mortality. So the premise was that if we managed to remove these bits of lung in the late 90s, early 2000, by lung volume reduction, that things may improve. And the premise wasn't incorrect. So this led, and I'll go through in the next few slides, the NET study. But how would this actually work? So they were actually going to target patients where we know the emphysema is most predominant, which is the upper lobes, and a bilateral upper lobe resection by a sternotomy. And this is a pictogram trying to show that using a sternotomy and trying to remove the upper lobes with the effect that would be projected to be shown as would be seen on these x-rays. So you would see that this is a patient pre-procedure and this is a patient post-procedure with improvement in diaphragmatic function, and the volumes of the lungs are reduced. However, things weren't as simple. So this goes on to the NET study, which was published in the early 2000s, which we all may have some idea of, published in the New England Journal, and showed, unfortunately, that there was no difference between medical therapy and surgical therapy, or lung volume reduction. And this was associated with high mortality rates in the high-risk group because of the targets that they used. Overall, the mortality was about just under 8%, low-risk patients about 6%, and in the high-risk about 10%. What they managed to show on subgroup analysis is that the benefits of having lung volume reduction, if it is targeted appropriately, would be to try and address the high-risk patients. I'm sorry, let's go back. Bear with me. High-risk patients, and who would show the benefit. Patients who have got a reduced exercise tolerance and possibly an upper lobe predominance, but it wasn't an absolute necessity, as I will show you in my subsequent talk. Overall, this led to a problem because we're not getting improvements in mortality, just some improvements in the patient's exercise capacity and quality of life. Now remember, those are very important things, although they might not sound so important in terms of mortality, they are important. So progress carried on, but there was a crisis. 10% is a very high number. We'll come back to these studies later on. Why do we need to offer patients lung volume reduction? So what was the rationale behind all of this? So we want to try and get a reduction in the hyperinflation. Now we very well know that removal of the dysfunctional dysfunctional areas of the lung, by remove the areas of emphysema, we can improve the diaphragmatic function, as I've shown to you in that X-ray earlier, and that helps reduce the work of breathing. By removing the destroyed lung, we improve gas exchange and therefore better ventilation and reduction in the right ventricular strain and development of pulmonary hypertension. Likewise, improvement in the exercise capacity of the patient, that they can do more and they can feel that their quality of life is overall improving. How do these mechanisms actually all work based on the reduction of the hyperinflation? So, bit of overlap between the two, and I'm going to repeat some of the bits. So there's improvement in lung compliance by removal of the excessive non-functional tissue or lung, enhanced diaphragmatic function by reducing the work of breathing in these patients, overall reduction in dynamic hyperinflation as would be assessed by increased exercise capacity, and improvement in symptoms of breathlessness in these patients. Now, these slides actually show what actually happens, the enlarged AP diameter of the chest wall, and if that is normal, this is what we would see in a patient who is hyperinflated, and we can see some emphysematous lungs there. Before I go into what we actually do at our MDT and how we manage these patients, I'd like to talk to you about this important scoring system, which is the Glenfield BFG score. It's based on BMI, F standing for FEV1, and G for gas transfer. And it basically uses the parameters of the patient to try and assess the risk or the prognosis of mortality or the benefits of having lung volume reduction. And based on the score, will determine the 30-day, 90-day, and 1-year mortality as shown here. Obviously, the higher the risk, the higher the risk. So the higher the score, the higher the risk of mortality. But we very well know it is more beneficial to do these procedures in higher risk patients, but you need to correctly choose your patients before you actually offer them volume reduction. And this is how a typical workout would be for a patient. So these are the things we would be looking for in terms of medical assessments. We'll be looking at their emphysema, BMI, steroid usage, if at all. They have to be non-smokers, completed pulmonary rehab. They would need to have a poor or obstructive pattern on their FEV1, ranging 15 to 45%, more around the 20 to 30% mark. A residual volume of greater than or equal to 175% or 200%, depending on whether it's heterogeneous or homogeneous emphysema, respectively. A reduced exercise tolerance in terms of 6-minute walk distance, between 100 to 500, but normally around the 200 to 200 to 300 mark mainly. An arterial blood gas, which is very important for assessing oxygen requirement and type 2 respiratory failure, or the raised CO2 levels. If you're going to do bloods, often worth doing an alpha-1 antitrypsin level. And if you don't have access to echocardiogram, then a BNP level would be helpful. If you have echocardiogram, that will be beneficial in terms of not only assessing the left ventricular function, but also the right ventricular function, especially to rule out patients with pulmonary hypertension, as it is contraindicated in patients with elevated systolic pulmonary artery pressures of greater than 45. And the most important test besides all of this is a CT scan. Can't do much without it. We use the HRCT scan with thin slices, and this is then uploaded, which I'll show you. I'll show you most of these things in the subsequent slides, how the data is actually used, onto a cloud-based system called Stratix, which we use to ascertain various parameters and factors that will help in management of these patients. And in addition, a dual energy CT scan. So what happens actually at the MDT? The MDT will meet up. Any patient can be referred by a nurse, a GP, secondary care, physiotherapists in the UK, or at least we take them. We assess all these parameters which I've been through, and then an initial decision is made whether they would be suitable for further review or not. And then we go on to deciding what to do next in terms of what has or has not been done. So what is actually discussed and what is excluded? So on the left-hand side, we have alpha-1 antitrypsin. Depending on how significant it is, we will try and ask them to be referred to an alpha-1 antitrypsin center unless there's a localized area, despite their raised in alpha-1 levels, to offer them bronchoscopic or lung volume reduction. If they've got raised pulmonary hypertension, raised pulmonary artery pressures, then to refer to a pulmonary hypertension center. If they require NIV, or if they're so severe that they need transplantation. In terms of optimizing their management, we would need to make sure they've completed pulmonary rehab, at least recently, manage their exacerbations. So one, maybe 2 exacerbations a year. People with more, we would probably decline or ask them to be improve their therapies to try and minimize their exacerbations, manage their comorbidities better, if they need oxygen, and also further fitness assessments. So coming back to the CT scan, what do we need to look for? And I'll try and show this pictorically in the next few slides. We assess the level of emphysema, whether it's heterogeneous or homogeneous, when we look at the CT scans to assess how significant the disease impact is and where it is. We also look at the fissure integrity, which is very helpful for managing patients with bronchoscopic therapy in terms of volume reduction, if appropriate. As I've said before, we can quantify the emphysema and subsequently, or with all that information, choose a suitable target. So this is a patient who has got significant COPD, and you can see quite a lot of emphysema. And the more important thing that I want to show to you is the fissure integrity, which is lost on this axial plane here medially, and in the coronal section and in the sagittal section of the CT scan. We can use dual energy scans. So on the right-hand side, on the left-hand side here, we can see that this is a ventilation, and you can see that there's poor ventilation in this patient. We can then get a heat map looking at the ventilation here at the top, and you can see that it's slightly reduced here, but more so here in the lower lobe. And then a corresponding perfusion evaluation on the heat map to assess what is going on. And then this is all summarized onto a table, which help us identify which would be our target lobe or target area to offer to these patients if appropriate. Stratix, as I've said to you before, is a cloud-based system where the CT is uploaded, and it helps to further emphasize or guide us as to what the fissure integrity is, which is the top bit here, fissure integrity. So in this case, I don't think the pointer is working now. Oh, okay. The fissure integrity on the top line, the voxel density, which is the Hounsfield unit, so the level of destruction in these patients, -10, -950, and then the overall volume. So you get a duplication, but also a reconfirmation of what your target is going to be. And all this information is very relevant in offering, or if appropriate, treatment to these patients. So come back to the decision-making tree. What does the patient want? Do they only want surgery? Then they would go on the left side. If you don't know or they don't know, then you can offer them the midpoint. And on the right-hand side, whether they want only valves or only suitable for valves, or if there is no intervention offered because we've not managed to optimize them. If they go in the middle part, then we have to do something called Chartis, which I'll show you on my next slide. And this is to try and to simulate blocking of the airway to see whether they would actually benefit from lung volume reduction bronchoscopically. This would be in patients who have no cross ventilation across the interlobe between the lobes. And if it is negative, then they will be suitable. If they're positive, then it's either surgery or no intervention. Once intervention has been offered and has been conducted, we would monitor the patient at our site, or we would review them again at 3 months. And in our case, we refer them back to our referring trusts, for ongoing surveillance, which is done on a 12-monthly basis. Often we would recommend, and this is what is suggested by BTS as well as the SCTS, for monitoring for up to 5 years. But often before that, if they're eligible, they would probably be coming back to have further therapy to the opposite side. So this is a pictogram or a movie clip on how the procedure is done in terms of Chartis. So a bronchoscope is introduced, balloon is inflated, and this balloon will then show whether the air is actually able to go through. It goes in one direction, so unilateral valve, and therefore leading to a subsequent collapse on the opposite side. And this would be a simulation of what the valves would actually be doing. And you would be keeping an eye on the flow volume of how much volume has actually come out. And once the volume is less than 6 mils, that would be an ideal candidate. Bronchoscopy will also help to remove any secretions, review the anatomy, etc., prior to inserting the valves if appropriate. So going back to the studies, going to the NET study, as we said, many other studies have been published using bronchoscopic evaluations for homogeneous, heterogeneous evaluation, Chartis, and some without Chartis, upper lobe, lower lobe. And you can see that things have progressed on. What we've managed to show on subsequent studies that have been published, mainly bronchoscopic, this is a bronchoscopic evaluation. Is there improvements in lung volume, minimal clinical differences achieved in lung volume, exercise capacity, as well as quality of life. So overall, what we have managed to evaluate is, as I said, lung function improvements, the patient's subjective perception of their condition, which is very important to them, their quality of life, the improvement in exercise capacity, which I think are very relevant. Complications, whenever you do something, things that you need to be aware of. And the biggest one here is pneumothorax. If you're going to get it, more than 75% get it within the first 3 days, and often we recommend that the patient remains admitted for the first 3 days, besides other complications. A bit about surgery. I'm not a surgeon, so I'm going to try and make this very quick. Is that surgery has changed since 2003 when the NET study was published. We are in the VATS, the modern era, as we would call it. And there's loads of new kits available. It's, bronchoscopy, we do it unilaterally rather than bilaterally. It's limited access, new kits, various ways of managing, and the patients have a better recovery. This is a short clip about a bullous resuction from which I've managed to acquire from my surgical colleague. And you can see that this is done by VATS, basically, which is laparoscopic evaluation and treatment. So removing part of the bullous lung. It looks quite short, but it isn't. I'm sure it's taken about 45 minutes plus to do this, if not longer. Just the procedure. But anyway, it shows what's going on resection wise. The destroyed lung is removed. They evaluate the area and look for whether there's any bleeding or any complications as a result of management. Okay, so to try and conclude, advanced COPD management strategies, we have to cater that towards our patient. You need to assess their endotype, whether it's an inflammatory pathway, a non-inflammatory pathway such as hyperinflation. There are new drugs in the horizon that are being licensed or in the process of being licensed. That's ensifentrine for patients who can be offered PDE3, PDE4 inhibition, dupilumab, the Th2 pathway, but also non-pharmacological management in terms of bronchoscopic as well as lung volume reduction, which have now shown improvement in both subjective and objective outcomes. And although there's no clear evaluation on mortality, I'm sure that will potentially come as we keep an eye on these patients. Before I open the floor for questions, I'd like to appreciate my colleagues. We have Mr. Asadi there, who is my colleague, who is the chair of the MDT. My other surgical colleagues, Mr. Anakin and Jonathan Finch, our radiologist, Paras Dalal, and one of the other radiologists is not on there, Dr. Skondras, and the rest of the referring team, without whom we cannot run our service. Okay, thank you very much.
Yeah. Dr. Jaymin, thank you very much for presenting the updated presentation of the recent the evidence and this one. Now the lecture is open for questions. If you have a question, please come to the microphone, introduce yourself, and you can have questions. We'll open the question time.
Hi, Keith, Dr. Jaymin, that was excellent. And I think one of the things that's quite good, and you mentioned very clearly, lung volume reduction still prognostically, is it helpful? Particularly if you've got a 10% chance of dying on the word go. But I think it's important to bear in mind they do actually symptomatically get better. And by improving their symptoms, in an odd way, the prognosis improves. They want to live longer. So I think we do need a bit more further studies, but that techniques have improved and hopefully mortality rate also gets less post surgery. So I don't think I want to be entirely negative, you see what I mean. So just a comment.
Thank you very much, Keith. You're absolutely right. So the studies to date haven't shown a prognostic benefit, but I'm sure as we keep an eye on these patients post trials, we will get evidence that I personally think that there is going to be a prognostic benefit in terms of mortality in these patients.
Good morning, and thank you very much for that excellent lecture. It was nice to see Jude there because Jude was one of my trainees way back when he was in Sri Lanka. Our cohorts of COPD patients are probably different from what you see. We have a significant overlap with bronchiectasis, as Dr. Madhagadar has published data on this. Does this make a difference? Do you think the new drugs like ensifentrine will be of use in these patients? And the role of macrolides in this cohort of patients, given the background of TB and the MOT, atypical mycobacterial disease in our part of the world, the role of steroids and macrolides. Would you like to elaborate on that?
So taking into the first bit, in terms of bronchiectasis. So as long as you can show that they're not exacerbating, whether if you're thinking about bronchoscopic, but I think your question was more directed towards PDE3, PDE4. I think that is the future. It was going to replace things like, I don't know whether you use theophylline much. We've stopped using theophylline in UK, or very seldomly use it. We try and use roflumilast, but the side effect profile, the GI side effect profile, is quite significant. I'm not sure about the cost implications here. So I think this would be, a new light possibly, and the side effect profile is potentially better. In terms of your second question, in terms of oral steroids and macrolides, there's always going to be that problem, and we have an infectious disease consultant here, a professor, who probably enlighten us more on that. But I think you're right. So we need to be cautious whether macrolides are the way forward, or whether you would use an alternative agent, such as doxy, or whatever the patient is sensitive to in terms of longer term management or cyclical therapy. Obviously making sure that non-pharmacological interventions like physio and chest clearance is better achieved. So I think it's trying to optimize them in a different way, and then trying to see what pharmacological intervention would be helpful for that specific personalized, in a personalized fashion for that patient.
Yeah. So akin to what Amita has said, that so when we encounter COPD exacerbations, we get the COPD exacerbation, which is bacterial exacerbation. There is raised to CRPs, patients is expectorating mucopurulent, and occasionally that we also get eosinophilic and allergic exacerbation, where the patient doesn't have any systemic symptoms and the inflammatory markers are normal. So when we classify the exacerbation of COPD and we trial these drugs, do we need to differentiate between these two categories of exacerbation, whether these are bacterial or allergic eosinophilic exacerbation, when making decisions on treatment to prevent these exacerbation? For example, we know that ICE inhaled corticosteroids increase the risk of pneumonia. However, it is not contraindicated in patients with history of bacterial. The bacterial exacerbations are not considered as a contraindications to prescribe inhaled corticosteroids. The same way with the efficacy of the dupilumab in patients who develop bacterial exacerbations.
It's a very good question. One would say that if you have type 2 inflammation, we have good evidence to show that steroids and or type 2 biologics may be helpful in these patients, whether it's a historic evaluation or a ongoing assessment of the eosinophilic count. In terms of overlapping with infection, I think it's important to treat the infection first before you would target that, because we know that steroids can immunosuppress and therefore make you more liable to getting further infections or bacterial infection. So I think it's sort of judging what is the right thing. Blindly using steroids, which we've done for a number of years, is slowly going to change. I think there's quite a lot of more evidence or new evidence coming that we should probably use bronchodilator therapy mainly for our patients with COPD. But I think that sort of will come over time. But you're looking at patients who are not getting bacterial or infections as the priority in terms of biologic therapy. If you go, that's what you're going to aim for, rather than using both antimicrobial as well as anti-inflammatory therapies.
Yeah, last question, please.
Himanshu Vikramasinghe. The question I have is, clinically, we have these patients that are considered COPD asthma overlap. And could some of these patients have been the ones who actually responded to dupilumab? And is this distinction important? Because I've used other biologics in the patients we call asthma COPD overlap with some success.
Absolutely. If there is an overlap, then yes, there is a good chance that these patients, but from my understanding, is that these patients did not have reversibility. They were true COPD patients. There might well be a small amount of patients who might have had reversibility, which is the main form of assessment to look for the asthmatic or bronchial hyperresponsiveness component of the airways disease. But I think they were more targeting or thinking in the lines of the inflammatory pathway rather than the airway reversibility component of it. But you're absolutely right. Patients are likely to benefit from Th2 inhibition if they have, an asthmatic or a eosinophil-rich inflammatory pathway.
Thank you very much, Dr. Morjaria, for that excellent overview of advanced care of COPD. And may I kindly invite Professor Dushanta Madhagadar to hand over the certificate of appreciation to you.